Right.
The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Welcome to our the webinar, Delivering Suicide Safe Care. I know that people are continuing to join on, but we're going to go ahead and get started. My name is Stephanie Shushan. I'm from Community Health Plan of Washington. And on behalf of all the Medicaid managed care organizations, we brought this webinar together with our partners from the BRE Collaborative, Kaiser, and other experts around suicide care to share this information with you. This webinar will be recorded, and feel free to, everyone will be muted, feel free to add any questions or information in the chat box, and we will have time, should have time for questions and at the end of the presentation. So I'm going to go ahead and get started. We have some great presenters that will be introduced to you. So Jenny Weir, Greg Simon, and Julie Richards, and Ursula Whiteside are all going to be presenting on delivering suicide safe care and the recommendations around this topic that were developed by the BRE Collaborative. So the objectives of this webinar is to give some background around the BRE Collaborative, provide some statistics around suicide within Washington State specifically, review the suicide care recommendations that were developed, and describe some best practices. And we will have some time for question and answers at the end. So I'm going to turn over the slides to Jenny Weir.
Thank you, Stephanie. So this is Jenny Weir. I'm the director of the BRE Collaborative, and thank you for joining us on this rainy morning. And I am lucky to be joined by Gregory Simon, Senior Investigator with Kaiser Permanente Washington Health Research Institute and Psychiatrist with Washington Permanente Medical Group. So thank you, Dr. Simon. Dr. Julie Richards, Research Associate with Kaiser Permanente Washington Health Research Institute, and Dr. Ursula Whiteside, the CEO of Now Matters Now, and the Clinical Instructor with the University of Washington. Now, I'm going to talk a little bit about the background of the BRE Collaborative. So we are a public-private group. We were created by our state legislature in 2011 to improve healthcare quality, outcomes, and affordability. And we're named after Dr. Robert BRE, a radiologist at Harborview and a leader within state-sponsored work to look at high cost of healthcare and overuse of services. We have 22 members who are appointed by our governor, and they represent different healthcare sectors. So health plans, healthcare purchasers, both public and private, including the Healthcare Authority, our state Medicaid agency, delivery systems, hospitals, quality improvement organizations, and clinician groups. So every year we select 4 or 5 healthcare services with a high amount of variation in delivery or outcomes that are overused or underused, and that might have a patient safety or an equity issue. And we're really a forum to impact change and through serving as a neutral convener and applying a standardized process to a diverse group of healthcare services. Our recommendations are based in clinical evidence, and we really work to facilitate buy-in on an individual and community level, starting with our development process. So once we select a topic, we convene an expert work group that's made up of clinicians who specialize in that healthcare service, primary care providers, researchers, patients or family members, health plan administrators, and community groups. And we'll spend about 9 to 12 months looking at clinical best practice, at published evidence, and at care pathways within our state and others, and also ways to impact change. So through changing reimbursement, contracting strategies, better data transparency. And once our recommendations go through a public comment process and are adopted by our members, we send them to the Healthcare Authority. And that is our primary implementation pathway. The Healthcare Authority is meant to incorporate our recommendations into their purchasing contracts. So outside of this public purchasing space, we cannot mandate adoption. So we do a lot of education, a lot of convening, and a lot of outreach. So these are our topic areas, and you can see we've really worked in a wide variety of healthcare services, from appropriateness of C-sections to increasing advanced care planning for end-of-life care to responsible opioid prescribing to creating some bundled payment models to push the system from fee-for-service to value-based. And our work is really developed from the ground up by clinicians and administrators for clinicians and administrators. It's not the state telling anyone what to do. They are just 1/22nd of a voice at our table. And behavioral health has been one of our primary focuses since we developed recommendations on integrating behavioral health into primary care in 2016. And since then, we've moved on to focus on implementation and expanded with specific pathways for screening, brief intervention, and referral to treatment for alcohol and drug use, for opioid use disorder treatment, and in 2018 for suicide care. And for the Bree Collaborative, this feels very salient as Dr. Robert Bree died by suicide. So this is created in his honor, and I feel like these recommendations especially really honor his legacy. So to talk just briefly about why suicide care was selected by the Bree and kind of our philosophy as we approach this topic. We really see this as a preventable public health issue and want to acknowledge that over 75% of violent deaths in Washington are by suicide, and firearms are used in almost half of all suicides. And for those ages 15 to 34, this is the second leading cause of death and the fourth leading cause of death in those 35 to 44. And there are real equity issues here too. So American Indians and Alaska Natives die by suicide at a higher rate than every other racial and ethnic group. And the rate of suicide is increasing. It's also higher in Washington state than in other states, and the national average as well. And the U.S. Preventive Services Task Force does currently not recommend suicide risk screening in primary care universally, but does speak to depression screening as a universal screening in primary care. And the Patient Health Questionnaire 9, one of the most common screens for depression, does include a question about suicidality, as do many other screens for depression. And this is really aligned with integration of behavioral health. It's also a state priority. So the Department of Health was a great partner in our suicide care work, and one of the other big motivators for us taking on this topic. In 2016, the DOH released the state's first across the lifespan suicide prevention plan, and this corresponded with our governor's executive order on firearm fatality and suicide prevention. So we really partnered with DOH in developing our clinical pathways and really see these as the next step for their strategic directions 1 and 3. So expanding access to care, standardizing care, making sure that everybody has access to high quality care. And these are our volunteer work group members. We're lucky to have such expertise concentrated in Washington state, and that our group is really willing to spend the hours they could be seeing patients or publishing papers or otherwise working, really sitting with us and collaboratively talking through how to develop policy and best practice. And we developed these 6 focus areas that our other speakers will go through in more detail. So this is our clinical pathway. And we really start with identification, followed by further assessment, then risk management and treatment. And we also wanted to speak to best practices for follow-up and support after either a suicide attempt or a suicide death. So now I will turn it over to Dr. Richards to talk about identification of suicide risk.
Great. Thank you, Jenny. I was lucky to be a part of the Bree Collaborative Suicide Safe Care Work Group under Ginny's expert leadership. So I'm going to be talking today about the first two focus areas, identification and assessment of suicide risk. And then Dr. Whiteside is going to be covering the other four focus areas. And Greg Simon is going to be wrapping up with some remarks about building a learning health system for suicide prevention. So for identification, the Berea Collaborative Guidelines recommend screening all patients over 13 at least annually for behavioral health conditions associated with suicide risk, including depression, suicidal thoughts, alcohol use, anxiety, and drug use. Based on screening results, the guidelines recommend following up with a more comprehensive suicide risk assessment, like the Columbia Suicide Severity Rating Scale. And I'm trying to, oops, there we go, advance the slides, and then I advanced them too far, so I'm going back. Okay, there we go. Additional risk factors as needed, so like substance use disorders or other relevant psychiatric symptoms or warning signs at the clinician's discretion. So here's an example of what that looks like in the KP Washington system. I'm also going to be sharing some results from 1 month of screening in our system. So a prompt in the pre-visit summary of our electronic health record reminds care teams when patients are due for screening. And we screen patients with a 7-item paper screen at the time of rooming. And that 7-item screen includes the PHQ-2 for depression, the Audit C for alcohol use, and 2 single-item questions about cannabis or other illicit drug use, or non-medical use of prescription medication. So when the PHQ-2 is positive, we ask patients to complete the additional 7 questions of the PHQ-9, which are located actually on the back of that screener. And the 9th question of the PHQ-9 asks patients about thoughts that you would be better off dead or hurting yourself in some way in the prior 2 weeks. And when patients score a 2 or a 3, and that's more than half the days or nearly every day, we ask patients to then complete the Columbia Suicide Severity Rating Scale. And we actually use a paper version of that questionnaire. And the first 6 items of that on that paper version are scored. And higher number questions are associated with increased suicide risk. So the 3rd question asks about, during the past month, have you been thinking about how you might kill yourself? And so for patients who say yes to this question and indicate some level of intent or plans for suicide attempts in the past month, there's a prompt in our electronic health record that prompts them to do a warm handoff to an integrated mental health specialist that works in the primary care setting. So that's usually a social worker in our settings, but we also have RNs that are serving in this role as well. And these RN and social workers engage patients in collaborative same-day crisis response planning. It's also called safety planning, and Ursula is going to be going into a little bit more detail about that. So if you look in detail at the cascade of how all this care works in our system, that happens about 24 times per 10,000 screening visits. We also have more information, detail, and some of our stories that we learned when we were implementing this work that are available on the reference here on that slide. That's publicly available. You can just click on the link and read more about it. And I should also mention that we're only screening adults right now in our system. We have not rolled out this care for kids, but we're hoping to be able to do that in 2020, and we're working through the workflow for that soon. So I'm going to hand off to Ursula next to go through the additional 4 focus areas.
Great, thank you, Julie. So in terms of management, once you've identified somebody who is at risk for suicide, so that's that person who, for example, on the patient health questionnaire said that they're having suicidal thoughts more than half the day or nearly every day. Once you've identified that person, it's important that you have a clear pathway for next steps and that your system understands those next steps, and also that those next steps are monitored so that you know what's happening in the same way that Dr. Richards was walking through each element of what happened with screening. You want to have that across the care pathway. You know how many people screen positive, how many of those people who screened positive received safety planning, and how many among those ended up to receive ongoing care and contact. And we'll talk a little bit more about that. in a moment here. But this is a big part, and this is where people historically fall through the cracks in busy, distracted health systems. That maybe they're identified, and we know that they're having suicidal thoughts based on their response to their patient health questionnaire, but then we lose them along the way. What's very important in this period, and not just the BRIE collaborative is saying this is important, but this is falling out in a number of national guidelines and recommendations, is that we create what's called a safety plan, and I'll speak more about that in just a moment. And key elements of a safety plan are that you address access to lethal means. One of the reasons this is so important, that is addressing access to lethal means, is that when we put time and space between someone and their preferred method of suicide, that reduces their risk, particularly when their preferred method of suicide is a firearm, or they just have firearms in the home, and that's because they're incredibly lethal. One point here to make is that many people, when they're beginning to work in the suicide prevention field, or to integrate new care guidelines into primary care, they get concerned that if they start to ask about lethal means, they'll have to take away the butter knives, they'll have to address all the belts, they'll have to do every single thing. And really what we're talking about here is addressing firearms, looking at their medication list to see what's reasonable, what's unreasonable, and then asking them about the ways they've been thinking about this. Primary care visits are obviously very short, and asking our primary care providers or their support staff to do this additional work can take some navigating, and I'm working with Summit Pacific Medical Center in Grays Harbor, Washington, and this is something we talk a lot about. But there are ways to do it, and it is incredibly important because you have that person whose risk is higher, in the same way that you have somebody who's got these high cholesterol scores and you need to create a more detailed plan. With safety planning, with managing that person and supporting the care for that person who's at risk for suicide, it's important to involve key members of their family. And one of the I'm just throwing in some clinical tidbits here, but one of the best ways to do that is to ask, who in your life do you really feel that you trust? Those are the kind of people that you might add to a safety plan, and I'll show you this in just a moment. The safety plan, or part of this management, is intended to help people in acute suicidal crisis, and let me give you more details on that. You see the word collaborative safety planning? That's very intentional. You can call it safety planning, but really the key here is this collaborative aspect. And historically, care around suicide has not always been the most collaborative thing. Sometimes this approach of we know what's best for you, you're unable to make decisions for yourself. But what we're hearing from people who've had these experiences, and there's a lot of us, about 4% of us in the past year seriously consider suicide according to SAMHSA. What we're hearing is that that's not useful, and that the collaborative aspect really increases the likelihood of having a positive experience and having a helpful experience. A safety plan generally helps somebody identify warning signs that a suicidal crisis is emerging. So for some people, that might be that they are withdrawing more. For some people, that might be that they're becoming more irritable or angry. Those are some identifications. Or it could be that they're in a situation that increases their risk. So they're around people that maybe they have in the past had trauma with, and therefore that's going to increase their risk. So there are all things to consider, not only the indicators for the person, but also the context within which they are. So right now we're giving you this very broad overview of these things, and for health systems that go on to do this work, it is a much more in-depth process, and so we don't want you to assume that this is something you can do overnight. One of the things that in health systems who do reviews of death around suicide, one of the things that they'll find is that people are dying by suicide by medications on their medication list, or that their medication list hadn't been reviewed, and there's a large number of those. I guess that's and people use medications that they had been prescribed. And so those are some simple things that you can do when someone's at risk for suicide, is to look at their medication list. And to also ask if other people have medication, large amounts of medication in their home. So in addition to asking about their methods, the ways they've been thinking about suicide, and asking about guns and medications in the home, you're also asking about the ways that they have coped in the past, what works for them, and as well as helping connect them to a social support strategies they can use for distraction, and contact numbers for family members and friends. Really what you're doing here is helping the person think through a crisis and how they're going to cope in that crisis. We always have people add the suicide prevention lifeline number to their phone when they've had suicidal thoughts. I think at the bare minimum, if you've got somebody who is saying they're having suicidal thoughts on their depression questionnaire, have them put the suicide prevention lifeline number in their phone. That's an intervention, and that's a part of a safety plan that takes 30 seconds, and that's a very valuable 30 seconds. This is the most common safety plan. This is the most evidence-based safety plan. It's the Stanley and Brown. Those are two researchers, that's their last name. And this follows what I was just talking about, the helping the person identify warning signs, internal coping strategies, people in social settings that provide distraction, people they can ask for help, and then identifying who it is that they can go to in a crisis. And the last step there, making the environment safe. It's important to know what people, why they want to live. And the newer version of this Stanley and Brown safety plan, which is free for use as long as you email them, the newest version asking, what's your primary reason for living? You want to be attending and moving towards that and putting attention on the thing that makes them want to live. All right, so this is the patient safety plan template. We're going to give you a couple more examples. At Kaiser Permanente, Washington, they developed a version of the safety plan called Crisis Response Plan. This is very similar, but what we're doing is demonstrating that people do this differently in different settings, but with the foundational pieces of, making sure you address access to lethal means, making sure you identify triggers or risk factors, coping strategies, and then connecting people to them in their own life. Connecting them to people that could be social support in their own life. Another example of a safety plan is the one that Summit Pacific Medical Center is. So I'm working closely with the head of primary care, Dr. Sean Andrews, and they're implementing this safety plan. This is a more in-depth one because it has a guide. So what they've been doing is giving this person who's identified as at risk for suicide a safety plan guide, asking them to read over it, going to see another patient, or asking them to come back next week and review it after making sure they've asked about lethal means and addressed the lethal means, had them put the suicide prevention lifeline phone number in their phone. They're giving them this tool. So that's another tool that's free to use, and that's on the nowmattersnow.org website. And what you see there is on the top left is just a documentation template. On the bottom left, there's a guide. On the top right, there's a safety plan, and those are all free for use. Okay, so let's move to treatment. Julie was talking about newly Dr. Richards was talking about screening and assessment, and I was talking about a care pathway and also safety planning. The next element in an ideal world would be people get treatment that was specific to suicide. This is especially important for your chronic patient who's having repeated suicide attempts and is struggling to get that behavior under control, I guess is one way you could say it. That's really important for that person in that situation to get access to a treatment called dialectical behavior therapy, which is developed at the University of Washington by a woman named Marsha Linehan. Now, dialectical behavior therapy isn't appropriate for everyone, the full treatment, because it's a really big treatment, but it is, it does include elements that could be used for all of us, which is dialectical behavior therapy skills. So newer approaches are that people are attending a component of that larger treatment. They're going to a DBT skills group, which is a class on how to manage suicidal thoughts and emotions. Whereas folks who are having repeat suicide attempts would probably be more appropriate for the full package. And evidence shows that both are effective, that the full package works, but then also the class with case management by itself works as well. There's also cognitive behavior therapy for suicide, it's specific. An approach called collaborative assessment and management of suicidality is also an approach. But here's where we can come in, following up with patients by initiating non-demand caring contact. That research, and actually very old research, has shown that staying in contact with somebody and showing regular support in very small ways, for example, a postcard, a letter, and yes, you can do a postcard in a HIPAA compliant way, can reduce the risk of suicide significantly. I think that this piece for primary care, for the therapy piece, is the most difficult to pull off, because trying to get somebody, as you well know better than I do, into mental health treatment, particularly a specific type of mental health treatment, can be quite challenging. And it's suspected that maybe only 20% of people ever make it to a specialty mental health referral who've been identified in primary care. And that depends on the setting, but we know that this is a big problem. But where we can, in primary care, be particularly useful is by figuring out a way, and I know I'm not assuming this is easy, but a way to help follow up with non-demand caring contact, and I'll talk to that in just a moment. A free resource that was developed by my colleagues Richard, and with the help of Dr. Simon, also on the call, is this nowmattersnow.org website. A guided version of this website is being studied in a large clinical trial for suicidal patients. So I was funded by the American Foundation for Suicide Prevention and the National Institutes of Mental Health. And it's essentially a package that was intended for providers to give to people who are struggling with suicidal thoughts. It's essentially what we wish we would have had when we're working in primary care settings, and you have that person, you want to give them something immediately that is evidence-based. And so that's what this resource is for. It's got safety plans and crisis lines and videos. And the videos are from that dialectical behavior therapy. It's teaching coping strategies for managing suicidal thoughts and intense emotions. That's your resource. That is free for you to use. And our most recent findings show that people visit that site and say they're suicidal are having less suicidal thoughts in under 10 minutes. That's also true for our teens and young adults. And what we know is that you all know better than I do, we're seeing increasing numbers of youth who are having suicidal thoughts. In fact, there's a 56% increase in suicide among youth, teen and young adults in the last 10 years. And that just came out from the CDC on Wednesday. After someone's made a suicide attempt, they're particularly vulnerable. And people leaving inpatient psychiatric units after treatment for suicide-related problems are at especially high risk for suicide. And that's why it's very important to follow up with people and to ensure a pathway to care. Now, if you're working in primary care, that's difficult because how do you stay connected to your medical or inpatient psychiatric partners? And that's a challenge to be addressed. So what I wanted to tell you is that way back in the 70s, a researcher named Jerome Motto did a study where folks who were discharged from an inpatient psychiatric unit for suicide-related problems and didn't want any treatment were randomized to receive something called caring contacts or no caring contacts. And a caring contact is a non-demanding expression of care and support. That's 1 or 2 sentences. And in this case, they were sent by mail and 4 years across time. That people received these monthly, then every other month, and then those diminished over time. But what they found was that for folks who received caring contacts, their risk of suicide was half that of those who did not receive the caring contacts. And so such a simple intervention has the power to reduce suicide. And this is where I think primary care is especially important. With almost 50% of people who die by suicide seeing their primary care provider in the month before their death, people are coming to us and they trust us, and we have this opportunity to do this brief intervention, this mailed intervention, or give somebody a caring contact card when we see them they're first identified. We have this opportunity to reduce risk, and these are some of the whys of why you would use them, but also the ways that you could do those. Postcards, letters, telephone calls, all of these things are things to potentially explore more. Here's a little clinical nugget. In talking to a lot of people who've had suicidal experiences, what falls out are these 4 things, that when you're sending a caring message, that these are the 4 things that they tend to find most useful. So anecdotal group evidence suggests that saying in some way or another, I see you, that you know how to do hard things, or I look forward to seeing you again, or I like you. So you may not use those specific words, but that would be the underlying message. Or referencing a memory could be particularly powerful. So I'll give you an example of one of these. Henry, before you go, I want to give you a card. I know that you've been going through a lot, and I'd like you to just put it in your wallet. Sometimes when things are really bad, it doesn't seem like there's many people who, believe in us or have our back. And I just want you to remember that I do. So I'm going to write this for you. And would you mind putting it in your wallet? So the primary care provider writes, I don't know you that well, but I'm glad you told me a little bit more about your life. Been through a lot, and I hope you'll come back to see us. With care, Nurse Matt. So in Summit Pacific Medical Center, what they've done is they've backed this process up. And so more of the work is being done with those people who are rooming the patient. And some of that work's been done with a nurse. So the provider's, role in this care for suicidal patients is not all of this stuff. It's reviewing the process at the end and working especially with those folks who have a current plan and some intent, I guess, how I want to say that. This is a great article. If you wanted to review the whole background on this field of caring contacts or caring messages, you could look at this article. It takes like 45 minutes to read, but it's fascinating. bit.ly/caring message with capital C and a capital M. Last thing we want to be sure to be clear about is that when suicide happens, it's important to follow up with family members or friends. A lot of times there's this concern about liability, and that for families who have been through this, their likelihood of taking legal action is going to increase when they don't feel like the care team cares. And that's what it can feel like when we shut down and we don't contact because we're concerned about liability. Well, we can always reach out and then say, let the family know that we're sending our care, and that we wish that the loss hadn't happened. You have to craft that language within your organization, but please don't leave people hanging in this situation. It's very important. A couple of resources. So the good news is that what BRIE Collaborative has done is paralleling with national movement called Zero Suicide. Zero Suicide, the elements match those that are recommended by the BRIE Collaborative with the additional element of engagement, improvement, where you're constantly managing and, you're constantly evaluating what you're doing in a health system that is doing suicide safer care. So you can learn more about that at that website, zerosuicide.com. There's a ton of resources there. That zero suicide approach, and by the way, zero suicide is, in Obama's budget and also in the current president's budget, and it's trickled down. So there's funding through SAMHSA, CDC, NIH. This approach is for healthcare and better, safer suicide care in the healthcare context. And this approach led to national recommendations for suicide safer care, and then also parallel the work that is being done by the BRIE Collaborative. The guidelines are that we identify those who are at risk via screening and assessment, that we engage in collaborative safety planning, including evaluation and removal of lethal means, and we do follow-up caring contact, those three elements. So at the end of the day, improving suicide care can feel quite overwhelming, but really those, I think there's agreement and consensus among those three things being important. This is what those national guidelines look like. One of the things that organizations have to figure out is whether or not they're going to safety plan with everyone who says they have suicidal thoughts. Well, based on research that Dr. Greg Simon and colleagues did, it might make most sense to do collaborative safety planning with people who are at greater risk. For example, so for those who are having suicidal thoughts more than half the days or nearly every day on that PHQ. But that's really an organizational decision. These are the three recommended standard care elements. And then I'm going to pass it over to Dr. Simon.
Okay, thanks, Ursula. I need to back up one. There we go. Okay. Whoa. Okay. I think I'm a little bit behind and I'm overcorrecting myself. There we go. So I'm going to actually sort of take a step back and give a little history, which maybe we should have done at the beginning. But to talk about sort of here at Kaiser Permanente, Washington, and then the other health systems in our larger mental health research network, which includes several of the regions of Kaiser Permanente and several other large healthcare systems around the country. We've been engaged in this work on identifying and addressing risk of suicidal behavior for several years now. This began, I'd say, probably around 2012, 2013. It's important to tell the story that it didn't begin sort of with a full-on focus on suicide prevention. Interestingly, it began sort of as the natural consequence of efforts to improve mental health care, doing the jargon term some of you may know is what we call measurement-based care, systematically assessing the outcomes of mental health care. So we had many of our mental health clinics and then our primary care clinics providers systematically using this PHQ-9 depression questionnaire. And a not small number of people on that 9th item that Ursula referred to said they had frequent thoughts about death or self-harm. And our providers came to us and said, what should we do about that? Does anybody know what the real risk is or what that really means? So we used the data that we had from our health systems and looked at that. And what we found was people's response to that 9th item of the PHQ was a pretty strong predictor of suicide attempt and suicide death following that visit, and that risk was very high for up to a year after that visit. So it was really the question from the front line that prompted the research that then led to some changes. And answering that question, or finding that fact that people's response to that PHQ-9 question was a strong predictor of suicidal behavior, led to a few different things. And I'm going to use those to illustrate this idea of what a learning health system is and what we hope to become. We brought these data or this information to the leaders of our health systems, and what they told us was, we believe we need to act on this. If you tell us that someone who says they have thoughts of death or self-harm nearly every day has about a 4% risk of attempting suicide in the next year, we believe that's high enough to be actionable. So our health systems implemented some of the work streams that Julie described to you earlier in terms of saying when We need our providers to conduct a standard risk assessment. We need to have collaborative safety planning that follows that. And then this led to this broader effort, what we call the Zero Suicide Program across these healthcare systems that we're now doing a fairly rigorous evaluation of to see whether we're reducing the risk of suicide attempt and suicide death at the population level. But the big point is that when we learn something, the first question is, what should we implement right now? What do we believe in what we have learned is actionable and that we're ready to move now? Our health systems said, we are not wanting to do a randomized trial of whether we should do structured risk assessments. We're acting on that. And as researchers, we stepped back and said, we're with you. We'll follow along and do the best we can to evaluate how well that works. At the same time, we were very concerned, that middle piece of the picture, we were very concerned about the large number of people who seem to drop out of care or disappear from care even when they were at risk. So things that our providers did during visits were not very likely to help people who were not coming back and making visits. We'd done a lot of work previously on outreach programs and care management programs that involve tracking people down and being very persistent in terms of trying to support them and get them re-engaged in care. And the question was, would a similar approach help to reduce risk of suicidal behavior in people who we knew were at risk? Our healthcare system said that's a big deal. It actually involves pretty significant resources, and also it's potentially intrusive in terms of bothering people and tracking them down. We'd really like some evidence that that works before we did that. So what that led to, and Ursula referred to this earlier, is a very large randomized trial that we're just finishing up now, conducted in several health systems, looking at the question of, will a systematic outreach program actually reduce risk of suicide attempt? And then finally, there are these questions that, as we answer one question, it leads to some sort of, interesting head scratchers. Even though we know that that item 9 of the PHQ is a strong predictor of suicide attempt and suicide death, we know that it's far from perfect, that it both misses some people who attempt or die by suicide fill out that questionnaire and say they don't have suicidal thoughts, and it's also not very good at identifying the highest risk people. So two other things that we've been working on in the interim, we've done some work using sort of more fancy statistical methods or machine learning methods to say, if we look through all of the information in people's electronic health records, can we come up with better ways of identifying people at risk? And the answer is yes, and we're working on that now. And then a very small study that Julie and Ursula were both involved in, reaching out to people who made a suicide attempt, as best we can tell, right after filling out one of those questionnaires and saying they did not have thoughts of self-harm, and trying to understand why was it that that happened. And it's a complicated story that we can talk about in the question and answer. But I bring that up here just to illustrate that even when we learn something, we can then say, but there's a gap in that knowledge, and what is it we need to do to learn something more? So this is my picture of this idea about a sort of comprehensive approach to suicide prevention. And that fits, though, into, now I do need it to advance. There we go. Whoa. Go back, yes. So this idea about a learning health system. This is my recipe, as I would say, for what it takes to bring all this together. In a structural sense, we're doing this work in large integrated healthcare systems that are responsible for defined populations of people. And I emphasize the responsible, that we're interested in looking at how can we reduce risk of suicidal behavior at the population level. It takes comprehensive and longitudinal records. We really need to be able to understand an entire population, what their patterns of health service use are, what are the opportunities for intervention. And it's important to have these data linked to mortality data. This is something our healthcare systems have been doing for some years now, systematically linking our membership data to state mortality records to say, and because of some of the things that Ursula mentioned earlier in terms of what we know about people's healthcare visitation prior to suicide death, we know it from being able to link to the mortality data. If we focus on those people who die by suicide who are engaged in care, we will miss most of the problem. And the people we should be most concerned about are the people who are disengaged from care. And those people, we learn about their death by suicide if we link to mortality data. On the technical end, we have a fairly well-established infrastructure for using those data for learning and improvement. We've built data resources important ingredient in this recipe, I would say, is the cultural change that it takes to really become a learning healthcare system. Having a leadership that's committed to continuous improvement. We really should look at our performance, identify gaps, and improve continuously. That we measure what we care about, and that's how we demonstrate that we care about it, and that we do that measurement to improve care at the point of care, at the individual patient level, but also for quality improvement. But probably the two most important items I left for last. One is developing a culture of transparency and trust. That it was a lot of work when we tried to bring healthcare systems together to talk about suicide prevention for people being willing to share data. By that, I mean willing to say, what really is the risk of suicide death in our health system versus your health system? What is the rate of suicide attempt in our health system versus your health system? If we look at our performance on various indicators of continuity of care for people at risk, how are we doing compared to this other health system? The answer, as is usually the case, was we were all doing not that great, and we were all doing about equally well. People are always so concerned that we will look so much worse than everyone else, and everyone has a lot of room for improvement. But that was a challenge in terms of bringing the health system leadership together to talk frankly about that. Once you get over that hurdle, though, then you can really accelerate the improvement efforts. And then finally is this, this idea of accountability, but to me a really important point, accountability within a just culture, which may be an expression familiar to many of you. But what I mean by a just culture is that we cannot hold ourselves accountable for everything we cannot control, but we can hold ourselves accountable for the behaviors that we commit to. And in the field of suicide prevention, that's especially important to say. We certainly would not hold providers accountable for every person who dies by suicide and say, you did something wrong, this is somehow your fault. And there is, as many of you may know, a history of the sort of, post-mortem or psychological autopsy in mental health clinics, which to my mind was very unfortunate and destructive, which, turned into who's to blame for this one. But when we've identified specific care processes that we believe really work, those would be some of the ones we talked about before. Do we screen everyone every year? When people screen positive, do we do a risk assessment? When the risk assessment shows significant risk, do we then work on a collaborative safety plan? We can commit to those, and on those activities, the desired rate is 100%. That we can commit to. We should be doing this every time because this is what safe care looks like. And that's something in our health systems we do systematically measure, and we do report, and we do, I'd like to say, at the individual level, the clinic level, and the healthcare system level, hold ourselves accountable for that. So although we may not be able to say that, we'll hold ourselves accountable for every bad outcome, we can hold ourselves accountable for every gap in the process. I'll say something that, Julie and Ursula have heard me say too many times, that zero suicide sort of call to action. I appreciate the call to action. I do have some concerns about, any sort of possible negative implications that somehow every suicide is should have been prevented or is someone's fault. What I always wanted to do was in between the zero and the suicide to insert the words zero defects in healthcare for people at risk for suicide. Which to me is what we should hold ourselves accountable for. But when I say that, you can tell why I'm not in the advertising business, because that slogan does not roll off the tongue. So that's the end of my remarks, and I think we're coming up on question and answer time, and we've got, we're good because we have about 10 minutes left for that. So I think now we're open for questions from anybody to any of the panelists, and I guess it's sort of free for all, and we'll have to see how that goes.
Great, thanks everyone. So participants, if you want to tap or type any questions you have in the chat box, we can get those answered. I can also try to unmute people with their hands raised as well. But feel free to enter any questions. There's also some resources that have been pasted in the chat box as well. So the Zero Suicide, Now Matters Now website links, and some PDF guidelines. Great. You guys can see Julie.
Yeah, I know Ursula was going to share her picture too. But yeah, I just wanted to encourage anybody to ask questions, or if there's resources that we can share, just please feel free to put them in the chat box, and we're happy to send you those.
So there are some questions. Will this slide be available for download? So we can definitely provide those. This is also being recorded, so we'll be posting this link and sharing this out. One question that we have is, what might be different to keep in mind when working with young kids around 8 to 10 years old? Are there any specific recommendations around youth?
Yeah, well, this is Greg. I'll start. I think one important, aspect of, being a learning healthcare system is being perfectly honest about things we know nothing about. And I would put that in the category of just being honest about, we really know very little. Most of the information we have about risk factors and understanding risk of suicidal behavior relates to adults. We've now shown a lot of that same information applies to adolescents. By adolescents, I mean sort of age 13 to 17. The information on risk factors, there has been some work done on sort of screening questionnaires that may be appropriate for school-age children, but that work is at the level of it's not at the level of saying we have, if the answer to this question actually predicts subsequent self-harm behavior or suicide attempt or suicide death. In terms of treatments or interventions, I think we know next to nothing. So I'm just being plain. That's something where it requires even larger populations and health systems coming together to learn, since the good news is that suicide death, fortunately, is that the numbers are relatively small in that age group. So my short answer is, good question. I don't think we know much. Let's get together and work on that.
And certainly 10-year-olds are saying that they're having suicidal thoughts. The numbers are much lower than the number of teenagers, but we know that 10-year-olds are going to be teenagers soon, and we know that the risk of suicide among teens and young adults has doubled in the past 10 years. And so going on what we know about what works for adults and teens, then we're going to want to be doing similar things, collaboratively making a plan for how to keep the environment safe, and coming up with some coping strategies for what to do when emotions get really intense and suicidal thoughts arise. And doing that in as collaborative a way as possible, and then really trying to get that child into specialty mental health.
We had a similar question about older adults. Are there best practices for older adults that are available?
One thing we have to just be careful about with older adults is that we don't assume it's normal to have depression and suicidal thoughts, and that certainly can, maybe Greg can speak more to that, but that certainly can be the case that things get written off when they shouldn't be.
Yeah, just to follow up, because this question came up, say, when we were using the PHQ-9, and there was that, question they asked whether they had, thoughts about ending your life or thoughts of hurting yourself in some way, and there was this idea that, a lot of people, who have chronic medical illnesses or cancer think about that, and that isn't really related to suicidal behavior in old people, but the data really don't agree with that position at all. That in older people, having those kind of thoughts is not sort of a part of normal aging. It's often a part of depression, which is a treatable condition in older people. And the relationship between reporting those thoughts and then subsequently attempting or dying by suicide in older people is just the same as it is in younger people. As many of you know, the highest rates of suicide death are actually in middle-aged and older people. So when we talk about prevention of suicide, we really are talking primarily about middle-aged and older people.
Great. There was another question about, we're currently using the Beck survey in our pediatric practice. Do you have thoughts on other appropriate surveys? I think this is related to children.
Yeah, I'm not sure if when you say pediatric, because I would distinguish between sort of ages 13 and up and under. The PHQ-9 questionnaire and the Columbia Suicide Severity Rating Scale have been well studied for use in adolescents, and that's why our health system sort of adopted those for age 13 and up. Those are not, well studied or I would say, appropriate for use in younger children. There has been some work about screening in younger children, mostly in emergency department or emergency room settings, using something called the ASQ. It's another questionnaire about suicidal thoughts.
We have a question about recommendations for resources for organizations that are having a difficult time changing culture and being more collaborative. And there might be resources we can send out afterwards, but if you have any recommendations offhand.
So I'll just say one quick thing about that. In KP Washington, what was really helpful for us was story sharing to sort of build that culture over time. And Ursula and Greg might have more specific resources, but I just wanted to mention that, in terms of building transparency and trust, it's not necessarily something that happens overnight, but it's really a process. And, just really working collaboratively with your healthcare systems was helpful at KP Washington, and really giving the providers the time and space to share their own experiences with the work and why it mattered to them was really important for us.
I would add too, the leadership piece is so important, that if you have a leader that's saying culture is really important, language is really important, we're moving forward with this, we're interested in people who are passionate about this, creating a team. I think that's really important. And the language piece is one thing that I think people can get around. If leadership says, hey, we're working on changing language to the newer recommendations, so those are things like using died of suicide versus committed, and those are things like using fewer words and using less judgmental words. Having a conversation around that can be pretty useful. There's a resource on that Now Matters Now website under free training resources that is a suggested language versus the old language slide or poster you can use.
Yeah, this, Greg, one thing I'd add that I think can be helpful, especially if there's, some sort of, concern or resistance around taking on this area of suicide prevention in health systems, is to point out how similar it is to a lot of things that healthcare systems accept as their core responsibilities and work on all the time. So if we think about, say, preventing cardiovascular disease, it's really not that different. We're saying we need to identify people who are at risk. We need to know, who's at high, medium, and low risk. We need to think about appropriate interventions to address that risk. We need to hold ourselves accountable for actually delivering those interventions. People who have high blood pressure, is their blood pressure controlled? Those kinds of things. And we need to have appropriate systems in place for people who are at very high risk, people who are seen in the emergency room for chest pain and things like that. And although, addressing suicide risk may, for people outside of mental health, seem like strange and scary, the fundamental principles are really not that different. And that, I think, making those points over and over again has helped to bring some of our health systems along.
Great.
Thank you so much for having us.
Yeah, thank you guys all for joining. There are some requests for resources that are in the chat, and we'll try to include those in our follow-up. And then, everyone feel free to also, look up our experts, the websites that they sent, so Zero Suicide, Now Matters Now, for any follow-up in the meantime. So thank you, everyone.
Okay, thanks.
Thank you.